enter questions in the chat. And of course, the session will be recorded unless there are any objections, mostly for note taking. This will not be broadcast over the internet. And also for reference purposes. So barring any objections, I will start the recording. Thank you, Tutor. We're just going to do some quick introductions here. And we're going to go with the subject matter experts at the site. So maybe if you could just introduce yourself and maybe say a little bit about yourself, a one-liner. We'll start with Dr. Moulson.
Hey, everyone. Yeah, I'm Nate Moulson. I'm a clinical cardiologist and one of the members of the cardiology team at UBC Hospital. So there's 4 of us overall that work there within the cardiology clinic. And I've had experience with CST working at St. Paul's and VGH as well so far. So I think that's why I was designated to be the one of us to join and go through this. Yeah.
Perfect. Well, welcome, Dr. Moulson. And then over to Michele.
Hello, I'm Michele Nelson, and I'm the receptionist clerk at the UBC Hospital Medical Clinic.
Perfect, welcome. And I just want to make sure that did Lauren join Tutor? No. Okay.
I don't see her.
Okay, sure. Then we'll go to Sonia.
Hi, good morning, everybody. My name is Sonia Reddy, and I'm the clinic manager for cardiology at UBC.
Perfect. Thank you, and good morning to you as well. And then over to the informatics side, I'll start with myself just because I'm one of the facilitators. Hello, everybody. My name is Vince Madrid. I'm one of the clinical informatics specialists with the medicine portfolio. I've been a nurse by background. Been on the project since 2018, so I was part of the Lionsgate go live. Was actually on the clinician side, and then jumped to the design side. Enjoyed it so much. And then we'll go over to Tutor.
Hi there, my name is Tudor. I'm a new CIS. I'm nurse by background as well, and just joined recently.
Perfect. Can we go to Mary?
Good morning, everyone. My name is Mary. I'm also on the medicine team here, clinical informatics. I have a nurse as a background, and welcome to joining you guys.
Perfect. And I'm just going to go back to the SMEs, and I see Lauren has joined. Hi, Lauren. My name is Vince Madrid. I'm one of the facilitators for this meeting. We were just doing some introductions. I just maybe if you could introduce yourself and a brief one-liner.
Yeah, hi everyone. My name is Lauren Sander. I am the patient services manager for CAMU, and the medical clinic is also part of my portfolio.
Perfect. Welcome and good morning. I don't think Anna's here. Abraham, are you here as well? No. We'll go over to Tyler then, please.
Hey, Tyler Childs. I'm the ambulatory application analyst, so I'll be helping actually build all this stuff for you guys.
Perfect. Simone?
Hi, good morning, everyone. My name is Simone Edwards. I'm part of the scheduling team. We will be meeting, I think, this week or early next week to review the scheduling requirements, and I will be building out that portion of Cerner for you.
Perfect. Jocelyn?
Good morning, everyone. This is Jocelyn. I'm a business analyst from the registration team.
Jenny, are you here? No, Agnes, though. I thought I saw Agnes. Ah, darn it, she's not here. Elena?
Hey, good morning. Elena's not here today, but Jessica and Megan are here on behalf of Elena with provider adoption team.
Hi, good morning. Elizabeth.
Hi, I'm Elizabeth. I'm with the provider experience team and looking forward to working with you guys to bring this clinic live.
Okay, perfect. And just if there's anybody else, and I see a few other people like Eric, maybe you could introduce yourself.
Hi, yeah. So my name is Eric Starr. I'm the informatics manager for the cardiac and ambulatory neurology portfolios. I've been on the CST and now on the VCH side since 2017, 2018, somewhere in there. And I helped the PHC cardiac clinics go live. So I'll be involved in more of a consulting fashion, just because we know what works for you guys really well with some of the stuff that you're already using. So I'll be guiding this team just with what I already know.
Perfect. Thank you. Faisal?
Hi, I'm Faisal Aziz from the Regional Cardiac Program. I'm the CST Working Group Chair.
Perfect. Welcome. And Mila?
Good morning, everyone. My name is Mila McEwen. I'm the Senior Manager across the ambulatory provider experience and patient scheduling teams with CST.
Perfect. I think I got everybody. Did I miss anybody? I don't think so. Okay. We're just going to
Vince,
move. Oh, yeah.
Can I just, it's Lauren. I noticed that Jennifer Ha is not on this, and I'm just wondering if we can make sure that we invite her to future meetings. She's our clerical supervisor across ambulatory at UBC.
Sure. Elizabeth, can you note that down, please?
For sure. I did see her on the invitation list. So I just wanted to make sure, did she not receive the invitation? Do we know?
Just as long as she's included. I know that she's got so many meetings. It's possible there was a conflict. I just want to make sure she's included. That's all.
For sure.
Thanks.
Yeah, I do believe she was invited.
Okay, perfect. Okay, moving on. I think we got everybody in that one follow-up item. Oops, where am I here? Purpose. So the purpose of this session is to gather requirements and learn your current state workflows of your clinic, which is the Medical Clinic 1 Cardiology Clinic, and to prepare for upcoming design sessions and validation sessions. So design sessions, we will review and confirm Cerner build options that will be used to meet and this clinic's identified requirements. And then the validation sessions review the completed clinic CST Cerner build for you. There will also be scheduling specific sessions, which you have stated, with specific SMEs, for example, the clerk for requirements gathering, design, and validation. And out of scope items for today's meeting will be added to our parking lot and reviewed at the appropriate session. So some guiding principles for change might be familiar with you. Some of the SMEs, seeing that you've been exposed to this already. Guiding principle number 1: no change for the sake of change. When we make change to a model system, if there are any safety implications, if there are any regulatory implications, changes that are required to meet regulatory and reporting requirements for national and international standards, financial changes that will create efficiencies without requiring significant operational cost implications, and content, of course, if it doesn't exist and it is required for go live. Guiding principle number 2, our focus is enterprise design. We're configuring for enterprise-wide, meaning all 3 health organizations, PHC, PHSA, and BCH. We prioritize our design topics based on what's needed in order to go live at each site, and that's chronological. And other design topics will follow a specific schedule as to when these will be accomplished in alignment with the go live roadmap. Of course, guiding principle number 3 is our priority is must-haves. So working together, creating a functional systems, and there will be opportunities later on to fine-tune the systems once we get everyone using Cerner. Must-haves, these are items which must be completed prior to activation, and then nice-to-haves, which are requests for changes or additional functionality that need to be reviewed and evaluated post-activation. Role of a subject matter expert. Again, I'll just breeze through this. Most of you are familiar with some of these topics here. So you're contributing as an expert or representative of your area to discuss workflows in your clinic and recommendations for future state workflows. You're able to understand and think strategically about processes and workflows within your setting. Also able to consider the requirements and needs of the stakeholders across all health organizations. Of course, you are familiar with the health organization policies and documentation, and able to confidently make informed decisions within your area of expertise. A SME will also collaborate with their clinic team to help inform the clinic design, responsible for discussing with the team and bringing back decisions to our design and validation meetings, and communicate outcome and impact of future design with the clinic team. Again, CST overview. I'm just going to breeze through this again. CST, which is the Clinical and Systems Transformation Project. We're transforming healthcare systems and processes to improve safety, quality, and consistency of patient care. We're rolling it over to all 3 health authorities and planning to continue to roll these changes out within the next few years. Again, about CST, trying to put patient safety first, improve quality and consistency of care, improve the healthcare experience for patients and the care teams as well, and to gather better data to improve health system planning, research, and proactive care. Now we're going to move into the clinical requirements gathering, clinic overview. Mary, I'll pass it off to you.
Great, thank you, Vince, and good morning, everybody. So we're going to go over some of things that we already know, which are a combination gathered from the clinic survey response and also the site visit that we had earlier this year. And so we're going to start off with the clinic description. So what we know is the clinic name as Medical Clinic Cardiology. We have both the mailing address and the physical address of the location, the telephone number, fax number, and that we know there are no satellite location for this clinic. We know that the clinic is serving both public and privately funded patients, and that in the space there are 3 pods with different rooms, and these rooms are shared between the different clinics. Can you just quickly confirm that is all correct?
The address is the same as the mailing address, room S267.
Okay, great, thank you.
That's
We'll
the
notate
location,
that.
yeah.
And Mary, just a housekeeping item, Westbrook doesn't have a T in it.
Okay, thank you. Are there any telephone number or fax number to the clinic that we are missing?
No.
Okay. Does this clinic do any clinical trials or research?
No.
Okay. Can you tell us if the telephone number and fax number listed here are shared between any other clinics?
Yes.
Yes. Can you tell us which ones?
Oh, internal medicine, geriatric medicine.
Everything that works, UBC Medical Clinic is a shared space. So any subclinic that works in the physical location will share that one number.
Okay, so does that mean the headache clinic, the
headache clinic is
respirology-
not, a headache clinic is not part of our build. Neurology is not part of our build, and medical biochem is not part of our build. Actually, nor is respirology.
Right, they're not part of the bill, but they do use these numbers. Is that correct?
No, they don't use, well, they don't receive fax. I don't receive faxes for respirology, no.
Okay.
But they could. That there are no other phone
They
numbers.
could.
Okay. And can you tell us how you booked the rooms for cardiology?
I assign the rooms based on who's working in the clinic that day.
Okay. And are there specific rooms that are booked specifically for only the cardiology purposes?
I assign the rooms every week. So generally they have the same rooms. Well, a couple of them, and then they can have other rooms. Yeah, they're shared rooms. They're all shared rooms.
Yeah, it's a shared space. So although because Michele sort of determines the schedule and who is going to go where, there is a preference that she puts certain people in certain rooms, but that's not set in stone. It could change just depending on who's there. So it's just an open space. People are using the physical location.
Thank you for that. Next, we'll move on to clinic days and hours. From the survey, we heard that the operation hour is Monday to Friday, 8 to 1600. Can you confirm that's correct?
Those are my hours. Yeah.
Okay.
Yeah, in the builds, Mary, with all of the other clinics that are working within the medical clinic, we just decided for the build that we would keep our standard operating hours as 8 to 5 or 8 to 1700, just to give us more flexibility because there's so much variability in people's schedules.
Okay. And still Monday to Friday for this clinic, is that right?
Correct.
Yeah.
Thank you. Now, are there any clinical activities done outside of the clinic operation hours?
No.
Okay. And are there any preparation duties to start the day?
I just assign the rooms to the doctors and prepare the examination room. Is that kind of what you're asking?
Yeah, or any clerical duties that you do before the patient comes in.
Not that I can think of, no.
Do you print any slates out or?
Well, yeah, I print a slate out for myself and for the doctors, yeah.
Okay, and does that slate contain the entire patients they're seeing for the clinic day?
Yep.
Yeah. Does it include the private patients as well, or just the ones that are coming for your clinic space?
It's just, yep, just all the patients.
And Mary, I see somebody has their hand up. It's Faisal.
Hi, I was going to ask, a number of clinics are not included. I didn't understand why. And what clinics are included in this discussion then?
Today we're only talking, Faisal, about cardiology.
But the other clinics sharing that space are going on to Cerner, like respirology, etc.
Respirology, I don't believe at this point it's being built into CST, because at this point in time, with the way that it's functioning, there's no PCIS entry being done. So we're just holding on respirology for now, but it may be a future build.
And then we also have Dr. Moulson, who also has a question.
Perfect. Now this is maybe just me catching up a little bit. So my understanding for today, at least, was a little bit of discussion around how CST would fit in with our logistics. And I think maybe Faisal, if I'm definitely correct me if I'm wrong here, but there had been some discussion around, so we've used a platform called iClinic so far for all our ambulatory care. And the rest of our division uses iClinic for all their general ambulatory care as well, including at VGH. I understand there are some differences between the settings. And part of what I was hoping to discuss, and maybe I'm not sure if this is the exact right avenue, but mine from our discussions kind of as a group, that if there would be an option to integrate, at least continue to use iClinic within the medical clinic as our primary kind of EMR system for our patient care, and then within and integrate it within what we need to from Cerner, because obviously all the cardiology testing and all that is being done that way, and seeing what that might look like. And so I'm not sure, I just want to put that out there for going farther down the road of developing all this, just to see if that had been previously brought up and what the avenues of discussions have been had for that.
Yeah.
Go ahead.
Hi, Dr. Moulson. My name's Lauren. I haven't actually met you in person yet, but nice to see you on Zoom. So yeah, no, you're right, for sure. We've recognized that you guys are using iClinic primarily, and we're not looking to create a whole make work project for the cardiology group. So I think right now the purpose is just to do the information gathering, and then we will be able to determine how best to move forward. And I think I've really only been part of one or two conversations previously, but I think the understanding is trying to only do the amount or type of work on CST that has to be done on CST, because otherwise it would be a massive disruption to the cardiology group, and that's not the intent. So I think we just need to go through the information gathering phase first, and then we'll be able to come back together as a group, particularly with our leaders, to just discuss how to actually go on to the next steps and roll this out.
Absolutely. Oh, thanks so much for clarifying that, Lauren. I was just a little thrown when you said some of the clinics weren't going through and pieces like that. So thank you very much.
Yeah, that some of the other clinics not going through CST at this point is totally unrelated to what we're doing with cardiology. So no concerns there.
Perfect.
And what my role in this is just really going to support those conversations. We've been through this before in other spaces, so we know what things you'll want to keep in iClinic from previous discussions and what things make sense to put in Cerner, and there will be a little bit of overlap most likely, and what overlap makes the most sense for your clinic is really what we'll want to discuss. And so you get the leveraging of the pieces of Cerner that will really make your life better, knowing that iClinic also does some things that you'll want to keep and you're not going to be willing to probably let go of, like your billing and things like that. So yeah, definitely we'll have those conversations along the way. So great for bringing that up.
Great, thanks, Eric.
Can I clarify from Michelle? Michelle, who does the PCIS entry for cardiology then?
We don't register. Oh, we register patients. That's me, but I don't schedule patients in PCIS. I just register patients.
Do you schedule them anywhere else, Michelle, or is someone else?
No. The clerks for cardiology schedule an iClinic. Yeah.
Great. Thank you very much. Going on to the next slide. All right. So in terms of clinic physicians, we know that there are physicians, as Dr. Moulson mentioned earlier, there's 4 cardiologists in the clinic. We have a clerk physician, a MOA medical office assistant, and a medical office assistant supervisor, and a clinic manager. Are there any positions that we haven't listed out?
I'm just wondering about the terminology of the medical office assistant supervisor. I'm not sure if that's someone that's related to cardiology, but there's definitely a VCH clerical supervisor.
Okay.
Yeah.
And
Hi, Lauren. I think that was meant to be for Sonia, but from our understanding, can we confirm that, Sonia? Is that your title?
I'm the cardiology clinic manager.
And underneath you, do you have, from my understanding, I think it's 3 office assistants, MOAs?
Sorry, and we have about 3 medical assistants in the office as well.
Sorry, Lauren, can you repeat the role earlier that you mentioned?
Clerical supervisor.
Is that's whose name is under that role?
Jennifer Ha.
Great, thank you.
You're welcome.
Are any of these roles on a private?
Yes, actually mine is private. And all the medical assistants in the office is private as well.
Okay. So both.
Just for the cardiologist, for all the cardiologists.
Okay, thank you. Any of these anyone play a dual role in their position?
No.
And can you confirm that this is a provider-led clinic with no nurses, no pharmacists, and no allied health?
That's correct.
Okay, and does this clinic have any medical students?
No.
No. Okay, thank you.
We may have medical students though at some point, Sonia, as well.
Sometimes.
As residents and fellows, yeah.
Thank you, Dr. Moulson. All right, next slide. In terms of the EMR system that's used, we know that there's PCIS for registration, iClinic that is used for registration and scheduling, CareCast, and Plexia. Can you confirm that list is correct?
Isn't PCIS CareCast?
Okay. Might need to update that. Sorry, then on survey we saw it was listed separately, so I was under the impression that it's 2 separate systems. Thank you for that. Can you talk about which user or physician access these systems?
Oh, if you're asking me, Michelle, I access PCIS, iClinic, Care Connect, PharmaNet.
Okay, thank you, Michelle. And how about the MOAs?
So I have access to PCIS, very limited. iClinic, Care Connect. That's, I think, about it. And
Okay. And any other system currently used in the clinic that's either custom built or to store records?
no.
Okay. And can you dive into a little bit of how PCIS iClinic is used in the clinic?
Oh, for me, PCIS, I register the patients. iClinic, I check in the patients as they arrive. And then Care Connect and PharmaNet, I print reports as needed. And demographics as needed.
Great, thank you. And Sonia, can you speak to the MOA piece?
Sure. I use PCIS just to print out labels and demographics for patients. We mostly use iClinic because all our scheduling is done through iClinic.
Great, thank you. So it sounds like Plexia is not used in the clinic?
No, not for cardiology clinic.
Okay. Great. Anyone else on the team have questions on this slide or to add to this slide? Okay, we'll move on to a referrals and triage question here. We know referral comes from the emergency departments, inpatient and community. They come through as fax and the clinic only see adult patients. Can you tell us if there's any other sources of referral?
Sonia, would you be able to confirm the referral locations, please?
Yes, so all the cardiology referrals come through to our office. We have a separate fax number for that. It's different from the clinic. And they are all being triaged by physicians depending on who it comes to. And they're all done sort of manually, they're not electronic. So yeah, once they get triaged, then we go ahead and book accordingly.
Okay, so did you say there's a different fax number for those referrals?
Yes, the cardiology office has its own phone and fax number, so they all come through us. So none of them get back to the medical clinic.
Okay, are you able to provide that number into the chat later on?
Sure.
Thank you.
Follow-up question for that one, Sonia. Is that one a paper fax machine or is that coming directly into iClinic?
It is a paper fax machine, yes.
Okay, thank you.
Okay. And just to confirm with these referral from the ED and inpatient, do they only just come from the UBC hospital or it could be all over?
All over.
Okay.
Yeah.
Including different health authority as well?
That's correct.
Thank you. Are there any documents included with the referral form?
Yes, they usually are, depending on if there are any testing done on the patient history, labs, yeah.
Okay. And are patients' referral ever rejected?
Really, that's on the physician, basically. They review the referral, everything gets triaged by the physician, and then they decide if they're appropriate for the clinic or not, but generally not. Most of them get accepted.
Okay, and if they are rejected, are they communicated back to the referral provider?
It is. It's back to the referring physician.
Is that something you have a form letter that you're just currently using, Sonia?
Yes, we do.
Okay, and it's like somebody like yourself that's sending it?
Sorry?
Is it like clerical staff that are just sending that letter? Like it's just, you put the patient's name in and send it?
Exactly, yeah.
Okay, that's good to know. A quick question, how do you divide up the referrals to various physicians? Do you have a, how do you make that?
Individually get, the referrals come to the physicians directly, so they have their names on it. It's not It's a safe cardiology clinic.
If it doesn't have a physician's name on it, who do you give it to?
Whoever has the shortest wait list, I would say.
Okay, so you guys make a decision on like basically on the shortest wait time. Cool.
Thank you. Can patient do a self-referral or come in without a referral?
No.
Okay.
It needs to be referred, yeah.
And do the cardiologists in the clinic do their own referral to the clinic?
Sorry, like the cardiologist referring patients to
the clinic, to the cardiology clinic at UBC?
as in booking testing?
Do you mean like from patients we see as inpatient assessments and things like that at Vancouver General?
Right.
So that would be yes. So like I'm on service somewhere, I'll refer patients to see myself or one of like usually myself, but I'm not sure if that counts, if that's what you're asking.
Oh, that's perfect. Yeah, that's exactly it. Thank you.
Are you currently doing like just sending an iClinic memo when you're doing that current internal referral?
Yeah, for the most part.
And does the MOA do any of the preliminary screening of the referrals?
No, we don't.
Okay. Thank you. Continue on with referral questions here. Are there priority status within the referral forms with patients?
Yes, they do.
And what are those? Can you tell me about those status?
Well, most of some of them come back as urgent or ASAP that we need to book right away, or some are elective or semi-elective.
And does the clinic ever refer to the ER or the inpatient units?
So,
I'm
I think
sorry?
you'd have to ask. I think you'd have to ask Dr. Moulson. I don't know. I mean,
Really, if someone is like, I think, you know, we do send patients to the emergency department, predominantly. I wouldn't say inpatient units, but on rare occasions.
Thank you. And for ED referrals to the UBC Cardiology Clinic, about what % of the referrals are from ED, and how are these referral managed?
I would say it's Dr. Moulson.
A lot of the way that a lot of our emerge referrals directly come to us from at least the UBC Hospital Emergency Department is actually through, like, we'll get called and then it'll be kind of a physician to physician, and then they will send, either we'll let Sonia or to know that this has been a referral, or I believe they'll just send a direct referral to us. So if I talk to the emergency physician, they'll just send a referral to me. We don't have a process. So like if they have an urgent clinic at VGH, the STAT clinic, and that's still where patients will get sent to from UBC if they don't talk to us. But if they want someone seen there at UBC Hospital, it'd be kind of a direct physician to physician. So there's not a direct form for that. Yeah.
Thank you.
And how do you communicate decline ED referrals? Would it be the same?
Yeah,
Yes.
Through fax?
Yes, through fax, phone, we contact the patient directly if you need to.
And our
So Mary, I think what I'm hearing is that if a patient in emerge needs to be seen by the cardiologist, it's a call that they make to the physician, whoever they can reach, and they say, can you see this patient? There is no paperwork right now. And if they can, then they probably will send paperwork at that time. Otherwise, they won't even send the paperwork. They'll probably send them to the VGH STAT clinic, which has a rotation of cardiologists seeing patients within 7 days.
Yeah, that's for the most part, Basil, that's how it works for UBC, because there's always one of us on call during the day to take consults for that, and so that's who they're able to reach.
Great. Thank you for that clarification. And for the ED referral seen by specific practitioner or given a certain time slot, so can they request a specific cardiologist to be seen at a certain time?
We provide the patient with what is available.
Okay. So it sounds like the ED doesn't schedule any appointments in the clinic. It's more like a conversation, and then the patient gets booked at the time that's available.
Correct.
Okay. And are the patients in the UBC cardiology clinic ever referred to a surgeon?
Yes.
Okay. Can you give some examples of type of surgeons they'll be referred to in your demographic?
Predominantly cardiovascular surgery, I would say, would be the main referrals, or to, I'm not sure if it counts for that, but like the valvular heart team, so interventional cardiology at St. Paul's and Vancouver General Hospital. And,
Great, thank you.
and less likely vascular surgery. Those are the main ones.
Thank you. Okay, moving on to triage. We'd like to know, is there a triage / screening process? If so, can you tell us about the process and who's there to triage the patients?
When the referrals come through, we just leave it out to whoever the physician that it's being referred to, and we leave it for them to triage and process it and get back to us.
Okay, so are all the cardiologists in the clinic involved with the triaging process?
That's correct.
Okay, and is there a specific day the day of the week that it's being triaged?
Not necessarily. They triage it as they come through. So it could be, they all work Monday to Friday, all different schedules. So they go through it as they can and when they're available.
Okay. Can you tell us about the inclusion and exclusion criteria for the triage?
Maybe I can help with this, Mary. I think the term clinic is a bit of a misnomer here. These are private cardiologists that are acting as a group. There's no formalized inclusion exclusion criteria. The triaging and the screening happens with whichever cardiologist is available. So they are essentially efficiencies for a group of private practitioners, and they are using space that is located in what's called the medical clinic, which essentially means any of the medicine practitioners at UBC are using a co-located space. So I think all of these questions, I'm kind of looking at them for the first time. They look very geared towards hospital clinics that have hospital staffing and that have built up criteria and triaging processes. And that's why some of these questions don't make all that much sense.
I see. Thank you for clarifying that. I think that is the purpose of this requirements gathering session, is to just fine tune and get a deeper understanding of this clinic. Let's see here. So what we can do is continue with the questioning, and then you can let us know if it pertains to the clinic or not, or is relevant to the clinic process. So earlier we mentioned in the referrals, priorities are set as urgent or non-urgent. And when we triage and you schedule the patient, are there any special priority used to sort out the referrals?
No, we basically go by whatever the physician has requested on the referral.
Okay. And if the referral comes in that that's accepted or rejected or incomplete information, who communicates the next step with the referring provider or the patient?
The office does, so we do it. We go back to
Okay,
the referring physician.
so it'll be the MOAs. If it's a provider, you send the fax?
Yes.
Okay, and what if it's the patient?
Sorry?
And for the patient, will you call them or how do you contact them?
Yes, we do set the notification back if an appointment has been scheduled for the patient to the referring physician to let the patient know. And if it's a patient that's referred to ER, we give them a call.
Okay, thank you. Now, once the referral is accepted, will the patient be required to do any labs or diagnostic prior to the appointment time?
Yes, that's correct.
Okay.
Depending on the information that was received and what the cardiologist has requested, we go ahead and arrange some testing. Most of them are booked with cardiology testing before they come in.
Okay, so it sounds like the cardiologist will order them.
Correct.
After that part of the question. And where does the patient usually go for these tests?
The cardiology lab at UBC.
Okay. And can you tell us what type of diagnostic is requested prior to the appointment?
They mostly a stress test or an echocardiogram or a Holter monitor.
And is there a prerequisite to have the diagnostic results prior to the appointment date?
Yes, we ideally like to have the testing done prior to the appointment.
Have them done and also the results to the clinic?
Most of them have a testing attached to their appointment on the same day, just prior to seeing the cardiologist.
Does this clinic use a wait list? And if so, usually how many patients are on this wait list and typically how long the patient stays on the wait list?
Well, all the doctors have different wait times. Some are a bit more expensive than the others. Yeah. So just depends on who they get referred to.
So in the referral, they can request to refer to a specific cardiologist, not just first appointment available?
Correct.
Okay, thank you. Okay, that wraps up the triage section of the question.
A couple questions just to help us later. For the diagnostics, are you guys currently booking into the eye clinic? Is there still the eye clinic slate available for the echo and the stress test available at UBC? And like, are you currently using those ones still?
Correct. We're still using them.
Okay, cool. That's good to know, just because we've already gone live in those spaces with Cerner. The other question I had was, so you guys are doing the coordinated booking. So like if you're going to book a patient, I was coming in and I needed an echo, you'd book my echo, you'd book my appointment. It would all happen hopefully on the same day to make it easier on me. That's something currently you guys organize right now?
That's correct.
Okay, and then the last question I have is around the wait list. I'm guessing the wait list is containing patients that are being directed via like ED and those kind of places where they might need like a 2-week or 3-week. It's okay to go for those ones if they're coming in to see you guys. And also patients that are like private patients are all being waitlisted on the same wait list.
Correct.
Okay.
I just wanted to add to that, the wait list kind of varies based on how long someone has been practicing. So it might vary for someone new to be months, to someone who's been there for a while to be years. And the second point is that scheduling the test and the consult visit on the same day is critical for UBC more so than other sites because it's kind of out of the way. So it's very difficult to get a patient to come there for an echo and 3 days later come back for a consult appointment. It's just removed from the lower mainland somewhat. So that's one of the important things to keep in mind, I think.
Great. Thank you very much. Any questions from other team members here in regards to referral and triaging? Okay, next we'll move over to scheduling here. We'll ask Tudor to take over.
Hi there. So we'll talk a little bit about scheduling. Again, we'll start with a section of what we know, some of the information we gathered from our previous meetings and the questionnaire. So some things we already kind of talked about, but just double checking again, just for our books. So again, our understanding is Michele registers patients, both private and public, in PCIS. Is that correct?
Yes.
Perfect. And then scheduling is done in iClinic by MOA.
That's correct.
Yeah. And then from the clinic visit, we understood that if we have no shows, Michele, you tried to contact them for follow-up, usually for at least 2 calls. And then after that, we put them in the miscellaneous box. Is that correct?
Oh, no.
Sorry, you're muted.
So if there are no shows for cardiology patients, we are usually the ones calling. Michele doesn't call those patients.
I see. So it's not Michele that calls.
No, not at all.
Oh, okay. Okay. Thank you for clarifying that. We just want to double check.
Just a workflow question for that. Who does the check-ins in iClinic at the front desk when the patient arrives? If I was coming there, who does the check-in on iClinic?
So I'm the clerk receptionist in the physical space of the medical clinic. So that's me.
Okay, and do you check in? Do you just check in only the patients that are coming for? Is it like all the patients for all the doctors you're checking in?
All the patients for all the doctors.
You're busy. Thank you for the clarity.
All right. Any other questions about the slide? Okay, we can move on to the next one. So just a couple of questions. So we kind of already went through that, but we just don't double check. In iClinic, both the public and the private patients are scheduled. Is that correct?
Correct.
Okay. And again, talking about that miscellaneous box, do you mind elaborating more on that? Like what happens to those people that after 2 follow-ups, there's
Oh, so no, you can delete that. That's again for internal medicine and gerry medicine.
Oh, okay.
So you can delete that.
You can do that. Okay. Perfect. Okay. But what happens to no shows after you try to call them twice, for example?
Oh, you'll have to ask Sonia. Sonia does the
Sonia.
scheduling. Yeah.
So we let the referring physician's office know if we don't hear back from the patient, and we leave it for them to let us know if they need the appointment or not anymore.
Okay. All right. Just to confirm again, the resources to work in the area and roles, we kind of already went through that, so I'm just gonna skip that. Who currently has access to book appointments in the area? Again, we kind of went again, but just double check again, it's Sonia and the other MOs.
Correct.
Yeah. Does other clinic book into your clinic?
Not for cardiology.
No. Okay. Are tasks such as scheduling, registration, referral, and patient check-in collected by separate individuals? We kind of already went through that with the scheduling and the registration. Registration is done mostly by you, Michele, or is that by Sonia?
Registrations in PCIS is done by me.
Yeah.
And the referral intake, that'll be probably Sonia.
They all come through our office. Yeah.
Yeah. And the patient check-in, I know Michele, you said you check in. Yeah. Do you currently schedule best coordinate appointments in other departments?
Yeah.
Are you currently using? Sorry, go ahead. Are you currently using automated appointment reminders?
Not for cardiology clinic.
Okay. And how many months in advance do you usually book the appointments?
It depends. Like I said, it depends on the referral, and if they're urgent and they're booked quicker, and then depending on the physician, and there are different wait lists. So there.
Yep. Move to the next slide.
Tudor.
Yes.
Can I ask that first line there is what do you mean by public patients? And secondly, I think how many months in advance? I think based on what I've seen, it can be a year out, if I'm not mistaken. Sonia, is that correct?
Yeah, that is correct.
Thank you for the question. I think
as far as 18 months in advance.
Yeah, thank you for the question. We just again, this is more from gathering from what our understanding is, trying to understand that in the clinic there are both public and private patients, and we're just more getting the details on that. And
so you mean public patients are MSP funded and
yes,
private
correct.
patients are direct pay? I understand.
Correct.
Okay.
Yeah. Okay. Approximately how many appointments do you have each week?
Is it for cardiology or
for cardiology? For
cardiology. Well,
roughly. I know it's might be hard to say number.
Cardiologists that work out of the clinic. So, oh gosh, about, okay, plus or minus 80 patients. Appointment. That's just an approximate, but could be more, could be less.
That's good. Just to give us an idea of the flow of people. And do you need to schedule recurring or repeating appointments? So like, do the patients have to come multiple times? Yeah, yes, you do. Is that quite often? Is that most patients? How often do you have to see that usually?
Well, it depends. Most of them, if they need annual appointments or 6-month follow-up appointments, then they come, but then we also have patients, that go for further testing and come back more frequently. So it all depends.
Yeah, and do you ever schedule coordinating staff that's external, like for example, pastor, social worker, maybe an interpreter? And we kind of have this question.
Yes, we do.
We do, yeah. We do. And what's your process usually for that? Do you put that in during your iClinic, doing the scheduling part?
Yes, I think we, Michele.
Yeah.
For the interpreter, what do we use?
Do you guys phone the interpreter and then book it?
No, I just use the login for the medical clinic one to set it up.
Oh yeah, you just do it all. Yeah, that's right. You just do it online.
So
yeah, you just book it online. Yeah.
Okay. Okay. Thank you for that. Any other ways for any other the services, or is it do you use anything else like the social worker or anything like that? Or, no, it's just mostly interpreter. We kind of went over it. We don't do a lot of walk-ins. It's all by appointment. If they do come in, but they're not yeah, you never schedule. How do you know when it's okay to book an appointment?
Well, all the cardiologists have the certain days and times. So as long as we have available slots, that's how we book it.
Yeah. So by appointment. Is a written order required prior to scheduling, like by the doctor?
Well, they all come back on the triage referral, right?
How do you communicate appointment information to your patients, such as like new appointments, reminders, or scheduling?
The notification goes back to the referring physician to let the patient know we do reminder calls a week prior to the appointment.
Quick question for you on that one, Sonia. Do you guys, why are you not using the reminder functionality in iClinic right now? Is it just not meeting your needs, or you just don't have that module, or?
No, it's just our patients come with multiple appointments that's linked with cardiology testing. So it just confuses the patient. They get multiple phone calls and they don't necessarily go in the same order. So they're all over the place. So that's why we don't use it. We just get somebody to just do a reminder call and then just go over the time. So they're
Got it. Okay. Just asking that question because we do have appointment reminders in Cerner as well. So to try and understand the rationale for what you guys are currently doing to make sense. So we can what we'll probably do is and this is just something for the team to take away. We'll probably include it in the build and they'll not use it because just in case something changes down the road, I don't want them to not have it available.
Okay.
Excellent. Just again, for understanding, what is the first stop for a patient makes when arriving for the appointment? Is it directly to the clinic itself, or is there another centralized registration area before that?
Again, it just depends on what kind of appointment they have scheduled. If they're coming in for the testing first, then they go to cardiology and then the clinic. If they don't have any testing, then they show up in the medical clinic.
And then once they arrive to the clinic, Michelle checks in.
Arrives them and then they get to see their physician.
And I understand for if there's any virtual ones, it is they're only done check-in through iClinic and Michelle does not have access to check them in. Is that correct?
No, the virtual ones, we just leave it with the physician.
Yeah. Are there any unique scheduling processes or acceptable workflow that we should be aware of for your clinic?
No, not necessarily. No.
Are there any hardships, major or minor, in your current scheduling process that you feel we need to address?
No.
Okay. And again, with the virtual health, is it mostly Zoom? Is it mostly telephone, or is it both?
It's mostly telephone.
Oh, okay. Great. Thank you. For helping management.
Perfect. Sorry. Thank you very much, Tutor. On to health information management. Just a few questions, and I know I'm looking at the slide next one. So some of them, these questions you've already answered, like you received into your fax line that's in the private doctor's office. You receive other documents there too, so you've kind of answered that as well. When you have paper documents that's produced out of your patient interaction, do you send those documents to health records for processing and storage, or do you keep them in the clinic?
If they're faxed to the cardiology office, they all go into our clinic. We're not sending to health records.
So okay, so it all goes to iClinic. But what about any paper doc? Here's a better question: is all the documentation in that appointment, is that all in iClinic, or do you produce any paper during that that patient interaction in that appointment when the patient actually is there?
No, they're all in iClinic.
All in iClinic. Okay, perfect. Answers a lot of that then. Do you need any documentation that might need to be scanned in color?
No.
No, okay. And of course, there's no storing of the charts because everything is done in iClinic. You gave us the fax numbers, and I think you answered that question about any documents stored on the drive. There are no drives that you're not using an A drive or anything like that. I believe you have answered that question already. Okay. So I just doing a time check here. It's 8:05. Does anybody need a break, or should we just carry on, knowing that it's going to be a full day? Okay, pending, I think it'd be good if we just went right through it, if everyone's okay with that. Just because I know everyone's really busy. If that's okay. Then tutor, maybe we could go on to the day of visit.
Sure, thank you, Vince. Okay, so let's talk about data visits. Michelle, from your report more. Again, we might have gone over a couple of them, we just double check again.
Okay.
So, the patients are checked in iClick?
Yes. Yes.
And then that alerts the provider. And then once they come in, you also probably update any information, and is that done in PCS?
Oh, if a patient told me they had a new family doctor, I can easily change that info in iClinic and PCS.
PCS, okay.
Mm-hmm.
Okay. And afterwards, you probably give the requisitions for follow-ups directly to the patients or via email? No, you don't. Okay. Okay. Do you fax them to directly to the diagnostics or lab if needed?
Well, I would.
Michelle, you're cutting out, but I think all of this patient interaction is happening via the MOA, not via Michelle.
Yeah, they would send it to do note in iClinic.
Okay, so then all the forms, okay, so then they would give the MOA will do all of them. Okay. Okay, good. Just wanted to double check that part. And we've already talked about the virtual health, and what we want to know is more of what do you prep in the day? I assume maybe print some up labels, anything like that, or is there anything else part of your chart prep?
If they want labels, they will request them.
Okay.
There's no chart prep because there's no paper charts, right? So I don't do any scanning into iClinic. The MOAs do that.
Perfect.
If the doctors want anything, I help them.
And Sonia, do you know what would be scanned in the system? If anything?
Everything, all the patient records are going to be already on iClinic, whether it be test results, lab work, history sent by GP. So they all are into iClinic. Unless there was something specific that our doctor went to feed on it, then we have to go and request it from outside. But other than that, they're all on iClinic.
Thank you. Okay, next slide, please. Where does the patient go when they run the clinic? It would be directed. We talked about this directed to the clinic office. Who is the first point of contact with the patient? That'll be Michelle.
Correct.
Yeah. And then anything in particular about the checking process that make a difference?
I just greet them, ask what doctor. Yeah, I'll greet them, ask what doctor they're seeing, check them off in iClinic as arrived, and then the doctor will know they're here.
Okay. And the doctor, I remember about the doctor knowing that they arrived, as you check them in. Do you also do like other clinics you write on a piece of paper that they have arrived?
Yeah, that's just for myself. I would just check it off on a printed day sheet.
Okay. Do you book last minute appointments for add-ons and walk-ins? You don't do walk-ins, but any for add-ons like last minutes?
Again, that would be Sonia's question.
It depends. It all depends. If there was an urgent one, I was going to ask the add-on you go ahead and add on. But no walk-ins. Usually don't get walk-ins.
Is there any specific intake documentations that have been done for the patients to fill out?
No.
No, okay. What type of forms or questionnaires do you fill out? Nothing at all? No. Okay. Any like COVID screening? I don't know if that's still being done, but just want
main floor lobby would be
lobby?
the COVID screen, yeah.
Okay. Okay. Great, thank you. And who updates the health history, such as immunization or anything else? That'd be you,
Dr.
Michelle,
Maybe
or
ask Dr. Moulson. Dr. Moulson is the physician, for example.
Yeah, it's all the health history is done on the inside.
Okay. Anyone else who reviews the chart usually prior to the appointments? Besides, I guess it'll be you, Dr. Moulson, and the other cardiologists, or is there anyone else that needs to review the chart?
No, that would be us.
Do pictures related to the patient care become a part of the patient's chart? But do you ever have to take photos of the patients or?
I can't think of instances that we have. Yeah, we don't really take photos and.
No.
So sweet and polite.
Oh, no.
No. Do you use any external documentation systems like Muse, HeartIS, or PROMIS?
Yeah, and we use Muse for confirming all of our cardiology graphics that are done throughout the lab there at UBC Hospital, as well as across sites. And then HeartIS is, we access that for reviewing angiogram results, but that's quite infrequent because most of the time those are uploaded into iClinic or into CareConnect.
Great, thank you. Is there a routine follow-up for the patients? 3 months, 6 months, or a certain time?
It'd be 6 to 12 months for routine follow-up. Yeah, and then urgent follow-up would be 3 months. Yeah.
Great, thank you. What is the departure process like for the patients? Like once the seen by the doctor, Michelle, is there anything else you do from your standpoints?
No.
No.
Nothing.
Nothing. Okay. Okay. What documents are given to the patient without them? No paperwork?
No visit summary.
Okay. Okay. Next slide. So just gonna go over procedure and treatment, and we just want to more just double check again that there's no procedures being done at this location.
No.
Right.
Oh, okay, great. That's what I wanted to double check. Great. We'll move on to laboratory and diagnostics. We're Mary.
Thank you. Yes, Michelle. Oh, okay.
Would you consider the ECG a procedure? Because we do the ECGs in the clinic.
Oh, you do that in the clinic itself?
Yeah.
Okay. And so usually you call someone to
The doctors do their own ECGs.
Oh, the doctors do their own ECGs.
Yeah, and sometimes we call the tech.
Okay.
Quick question regarding that one. If Dr. Moulson, if you're doing your own ECG, do you guys upload those to Muse or are you just reading them separately?
We just review them separately and put them in iClinic. So this is just for ECGs that we do the day of that are not like already done in advance or anything like that. So we just have a machine.
Okay. Okay. That's fine. Cool.
Michelle, sorry, follow-up question regarding the ECG. Is there a particular treatment room that's done or the same room that they provided?
The exam room, yes. Now, occasionally, so speaking of Muse, if they want the ECG in Muse, then we call the cardiology technician to do an ECG. And that happens not very often.
Okay. And do you know if they need that in advance, or is it
Nope,
predetermined?
they'll tell me, nope, they'll just say, oh, do you mind calling the cardio tech? Or they'll just go ahead and do the ECG themselves.
Okay. So it's kind of decided on the spot based on the need of the physician?
You got it.
Okay.
Michelle, since
Yes?
Cerner has gone live at UBC within the cardio diagnostic space,
Right.
how many times have you had to call for ECG and what did you do to get it done?
Oh, so I just fill out a paper cardiology requisition. Sometimes the internist will want an ECG, and sometimes maybe Dr. Isserow will. Like I said, not very common, just a paper requisition. And then I phone the cardiology department and say, can I have portable ECG? And they'll come over. It's just more convenient rather than having the patient leave the clinic, go across to cardiology. They just come to us.
Okay, thank you.
Great, thank you. There's no other questions from the CST team regarding to the procedures and treatment. I'll move over to the laboratory and diagnostic portion of the requirements gathering. So currently we know that there's no labs done. There's ECG done in the clinic. Clerk either provide the requisition forms to the patient directly or via email, or they will email or fax the requisition to the test site directly.
Not the clerk, not me. That's MOAs.
MOAs, okay, thank you. And so this will also be the MOA that sends the requisition directly to Life Lab Central Intake if needed.
You'd have to ask Sonia.
Okay, thank you. So what we'd like to know is that which facility or organization provide laboratory service to your clinic?
Well, diagnostic-wise cardiology, we fill out all our requisitions from our clinic. So they're all accessible to the clerks in cardiology. And blood work stuff, we send it through Life Labs, we give it to the patient, they take it to whichever lab they want to take to. And then MRIs and stuff, they're all done through our clinic and they're faxed electronically.
Is the patient asked to use the hospital laboratory for any specific tests?
Not necessarily.
No, okay. And these tests, can they be performed on-site or external?
Yes, they can be done on-site depending on if patient prefers if they're from they don't live in Vancouver, they want to take it outside of Vancouver, then we're more than happy to give them a requisition and provide them with whichever location they want to go to.
Okay, so aside from the ECG, can you tell us more about what kind of tests that can be performed on-site?
Echocardiogram, stress test, Holters, 24 blood pressure monitors. I think that's about it for cardiology.
Well, I guess you could call lab or X-ray or CT.
Oh yeah, outside of cardiology downstairs, yeah.
That's perfect. That answered the next question for special imaging. Okay.
Yeah.
Any routine tests required for a patient? So that would be aside from. Sorry, are there any routine tests? I shouldn't assume ECG, but.
The most of our cardiology patients come in with a stress test, but like I said, they all are different depending on what the cardiologist has ordered.
Okay.
Individual case.
Okay. Can you think of any other diagnostic tests that we haven't touched on?
No, I think that's about it.
Okay. So we heard that the results come back either through the Muse or the Heart-IS. Any other EMR that the results will come back to the clinic?
iClinic.
In iClinic, okay.
Yeah.
So I think all the results come back to iClinic via Accelerus.
Correct.
Okay. Thank you. And any of the lab staff at the UBC hospital perform blood collection inside your clinic space?
Nope.
Okay. Thank you. All right, we'll move on to the order set question here. So the CST order set team, in collaboration with the providers and non-provider subject matter expert, design, builds, validates, and maintain power plans in the Cerner system. They will have a separate gap/requirements gathering sessions to gather details. Order sets team will collaborate with the CST2 informatics to ensure workflows are followed and supported. So there will be more questions about order sets, but we'll just kind of do the foundation questions at the moment. So next slide. So we know that currently in the cardiology clinic, there is no PPO and no medication given at this clinic for cardiology unit. Is that correct?
Correct.
Okay. Can you confirm that the cardiology clinic does not use any pre-printed orders or order sets? And that and if there's any current order sets that you're in process of creating or want to create?
We don't use any, no, and not necessary, I don't think, yeah.
Okay. Are there, maybe this is for Dr. Moulson, is there any common groups of 3 or more orders that are frequently grouped together for treatments or for the appointments?
I mean, not off the top of my head, more than 3, no. Yeah.
Okay. And do you have any of the clinical pathways or protocol policies that are included within the orders themselves?
No.
Okay. And do the provider typically place a lot of orders as a baseline? If so, what are the frequencies and what are the orders?
I guess as a baseline for follow-up testing would probably be things like exercise, if we're doing like exercise, stress tests, echocardiograms, and blood work, Holter monitors would probably be the main ones. Frequencies, it depends on the patient, hard to say specifically, but blood work would probably be the most common thing from follow-up and stress tests and Holters.
Great, thank you. Next slide, we have an order set form here for saline suppression test order. We want to know if this is one of the forms that came in as a bundle for all of the clinics. So we want to know if this is used in the cardiology clinic.
Not for us, no.
No, okay.
That's internal, internist. Yeah.
Great. Thank you for clarifying. Moving on to the reports and billing requirements gathering questions.
Mary, one thing we didn't, I don't know if it's coming later, is there any prescriptions? You haven't covered that?
Prescriptions.
I think we do cover a little bit more when we talk about the day of provider, and that's just noted there.
There'll be a section later on for providers day in the clinic. Thank you, Tudor. In regards to reports and billing, we know that providers do their own billing. We want to know in the clinic, what kind of reports do you run?
Me? No, nothing.
Nothing. Okay, and Sonia?
No, nothing.
No report. Lauren?
You print out slate reports. You print out reports for any other areas that might have slates or anything like that that we can think of just for adoption purposes.
Like the day sheets?
Yeah.
For all the clinics. Yeah.
Do you print them out for any other areas too that might be related but not really physically in your space?
Not physically in my space? No, I wouldn't print a day sheet.
Yeah, I just don't know if you care about what's going on in CT scan or something like that. Like you might, sometimes people have weird needs, right? So.
Oh, I see what you mean.
Yeah.
Nope.
Okay, cool. Thanks.
Okay. Sorry, Sonia, do you run any reports?
Sorry, no, I don't.
No. And Lauren, any reports from your end?
No, as far as I know, historically, the medical clinic hasn't really run any reports, but that will change in future state, and we'll start from the ground up and use what's available in CST.
Okay. Can you elaborate a little bit more with what kind of reports in future state you're looking for?
We'll do data metrics and stuff like that for throughput.
Okay, thank you. And Dr. Moulson, any reports from the provider end?
Nothing specific, no.
Okay. Okay, and we'll skip over the reports question.
Dr. Moulson, slide. I'll just point out a point of clarification for the what we know side. So providers do their own billing. What drives the billing is the scheduling in iClinic. I think is the beginning part of it, and then iClinic is actually the place where the billing codes actually go directly into, and provider billing is automated through iClinic. So that's just something to keep in mind.
Okay, thanks, Eric. And just to clarify one point here, do both private and publicly funded patients go into iClinic?
Yes.
Yes, they do.
Thank you. All right, so let's see. Let's confirm, how to provider complete billing? So just in iClinic, and is there more steps afterwards?
Those two, as we're doing our billing from a billing agent standpoint. Yeah.
Are there any external reports or system or clinic EMR that used to facilitate billings?
Just iClinic, what Eric's mentioned. Yeah.
Okay. And does the clinic see non-residents or uninsured patients?
Yes, on occasion. Yeah.
Okay, and how are they billed for their service?
Maybe I'll let Sonia answer that one.
Sorry. The patient is invoiced directly for their services.
Sorry, maybe it's just my mic not clear. Can you repeat that again, Sonia?
So the non-insured patients, we invoice the patients directly for their services with the provider.
Okay, you billed the patient directly, and is that something they pay at the clinic or they receive a bill at later on?
They receive a bill afterwards, yes.
Afterwards, so it's also documented in iClinic as well?
Yes, everything's uploaded into iClinic.
Sonia, does any of that go through the finance department, or is it all directly just managed by your team?
We only invoice the patient for the provider. Any testing that's done to the hospital, depending on the cardiology, if they have any cardiology testing done, that's done through the VGH finance. That's not done.
Okay.
Thank you. All right. We have no other questions from the team regarding reports and billing. We'll go over to forms. Tudor.
Hello again. Yes, so we'll go over some forms. I don't want to go through all of them. A lot of them, what we've gathered, seems to be a lot of referral pages, and because it was all combined with all the other parts of the clinic, we just wanted to clarify which ones we want to use. Two of them that really came forward that might be with you would be there's a hospital high blood pressure clinic.
There's no high blood pressure clinic at all.
No, but yes, but I just want to double check if that form is ever used.
Those doctors retired, so not at all.
No, okay.
Yeah.
You can try, but it doesn't sound like you're going to get anywhere with that form.
Yeah.
So they must have dug it out from one of my binders somewhere that I still had kept, but yeah, they retired.
Perfect. So that means, like, again, I think we went over this again, but there's no actual form that's done, Dr. Moulson, that's actually written down. It's all charted on iClinic. Yeah. Okay. Okay, and I think there was a couple other forms. So the left top one, that's the refer form. I think Eric actually put in the chat as well. That's the usual form that you guys use to receive your referrals. Is that correct?
Yeah. Oh, isn't that the regional referral? Yeah.
Yes. Yeah.
So
okay,
that all goes to Sonia. Yeah.
Yeah, tell Sonia. Yeah. And then the other ones we were curious about, there was a couple on the left bottom side. There's a couple of NBB stress test records. And we just want to double check that those are ever used. But they look like they're the ones that actually were recording NBB. So we just want to double check it. I know you said there's no procedures, but just wondering if you ever have to print them out for a certain area and then leave the chart. I know some areas might do that. So just want to double check that. Is ever used here?
Not that I'm aware of.
No, okay, perfect. Great. Does anyone else have any other questions about any of these forms? Okay, then we'll move on to restricted clinical trials. Again, just double check that there's no clinical trials happening. Or do you see any clinical trials that might happen in the future?
When we do a reasonable amount of research through it and how much is overlaps with this, but most of it's out of the sports cardiology center, which is kind of adjacent to it. So I would not say specifically through the medical clinic, no.
So would you say like almost pretty much 900% is through the sports clinic then?
Sorry, yeah,
I'd say, yeah.
Yeah, the vast majority is through the sports clinic. There will be patients that will be seen potentially there, but if they're going to be involved in research, they'll be directed to the research center, which is just physically adjacent to the clinic.
That answers that question. So we can move back to Mary.
Great, thank you. So we'll go over the provider clinic workflow here. So we know that the provider documents in iClinic, and we'll ask for a follow-up visit appointment, usually about 6 months, Dr. Moulson said earlier?
Yes, yeah.
Okay, if it's urgent, it'll be 3 months. And we have the list of providers here.
Yeah.
Okay, Dr. Moulson, can you tell me, are there any narcotics prescribed in the clinic?
I would say no, yeah.
Okay.
Or extremely infrequently if that happens. Yeah.
Okay, so the reason why we ask is that do you foresee that you need a narcotic printer in the unit? So
I would say no.
no, okay.
We'd already decided that we would need one for internal medicine, so yeah.
It'll be a shared resource. One will be available in the clinic.
Okay, great, thank you. Does the provider refer patients to other specialists? And if so, what are the common ones they do get referred to?
Yeah, so we would refer for sure. A lot of I'd say the vast majority of the specialists being referred would be kind of subspecialty areas within cardiology. So electrophysiology, cardiac rehabilitation, to anyone on that kind of general referral form, the valve clinic, interventional cardiac surgery, things along those lines. Also like hypertension clinic, like at St. Paul's or VGH would be another one. Those would be the main ones, I would say.
Okay, thank you. Any ones that are outside the lower mainland or to other health authorities?
Typically not, but we're like a very tertiary referral basis for patients within our area of expertise. So we will see patients that come in from all over the province. So we will be referring them back to potentially, like if they're from interior health, for example, to an electrophysiologist or someone within interior health potentially. But so that does happen.
Thank you. Would the provider like to be notified if the patient has been admitted to the hospital?
I'd say ideally if there was an easy mechanism for that. We don't have a mechanism for that right now. Yeah.
Okay. And are there standard appointment times for each of the providers?
In terms of duration of appointments?
Correct. And also, for example, if you only see patients from 8 to 10 o'clock during the day?
Yeah, I think we all have our different schedules of days of the week and timings and things along those lines. I don't have all the details from every individual. If you require that, we can get that. I'm sure Michele or Sonia can provide some more details around individual providers too.
Okay. And usually the appointment times are roughly how long in duration?
They typically for a new patient, 30 to 45 minutes and a follow-up 15 to 30 minutes typically.
Okay. Thank you. When the patient, if the providers completed their appointment with the patient, how do you communicate the follow-up appointments to MOA or to rebook?
So physically there, so a couple of things. Either they would go over to the booking desk or to where MOAs are located, or send a message through iClinic, and then the MOAs will follow up with the patient after the fact, give them a call and book that appointment for them.
Gotcha. And how about for the virtual visits? How do you inform the clerk or the MOA that the appointment is completed and a follow-up consultation?
Yeah, so typically if it's a virtual appointment, I'll be on iClinic call the patient, check them in when I'll be able to just quickly click arrived when I actually get them on the phone or on Zoom. And then when the appointment is completed, I'll just send it to do of my list of what requisitions I filled out within iClinic and what the follow-up duration, and then that will be taken care of on the MOA side of things.
Great, thank you. Can you talk about how discharge to handle?
So I guess that's pretty much it. From the discharge would be from either if they're in person and then they require follow-up, they will go directly over to the MOA desk to get the follow-up testing booked. If there's nothing that needs to be done at that time, they will actually physically just leave the clinic at that point, and virtual will be just a sensation of the contact, and then that'll be the discharge.
Are there any kind of forms or like a summary given to the patient?
No, we don't give any the patient summaries at that time.
Okay. Thank you. More questions on the next slide here. Do providers have standard documents templates that you use?
So that depends on the provider. We do have some within iClinic that are like preset templates for our clinic specifically, depending on if we're, different types of patients. So if it's related to certain areas of specialty, so like sports cardiology, for example, we have templates that we use within iClinic. Not all of us use those though. I personally do, and they're just kind of pre-populated with some of the data from there. But otherwise, they're just the dictations into the system, the PCIS.
Okay. And do you have any standard provider letters given to the patient?
Standard provider letters, like no, we don't think we have any of those. Yeah.
And can you tell us what medication or orders by the providers?
I think in addition to what we already talked about there, from like stress tests, Holters, ECG, so cardiology graphics, imaging, so echocardiograms, presenting or nuclear maybe tests, and then MRIs, I think would be the big ones, and cardiac CT. And then lab work, so just kind of basic lab work, and lipids, diabetes, etc. And then medications, which is the range of cardiac meds.
What are like the common medications would you prescribe to the patient in this demographic?
Yeah, so I guess it's pretty broad because it's a general cardiology, so it's not like a specific like heart failure clinic like that. So it can be ranging from anything from preventative medications, so antihypertensives, cholesterol medications, antiplatelet agents, all the range of heart failure medications, all the range of antiarrhythmic therapies.
Okay, thank you. And then are the prescriptions commonly given to the patient, or does the clinic normally fax to the pharmacy?
Yeah, a little bit provider dependent there as well. It can be a combination of both. Typically, I personally will print the prescriptions off from iClinic and just give the patient the prescription at the time of the appointment, or have them faxed off if they request that to be done at the time of the appointment as well. And virtually most of the time it's being faxed off.
Okay, thank you. In terms of the medication reconciliation,
oh, Mary, I just have one more question for Dr. Moulson. For that faxing from iClinic, is that functionality within iClinic? Or do you print and fax?
I believe it's print and fax. Usually I just fill the prescription and then send it to you, and then then the MOA will take care of that.
Okay, good. Good to know. I just wanted to double check on that. Thank you.
Actually, the functionality is within iClinic, so it depends on the provider. They can fax directly from iClinic.
Okay, thanks, Faisal.
Yeah, Faisal's correct. I don't think any of us use that functionality within our clinic. Correct me if I'm wrong, though, Sonia.
No, that's correct. We do have that feature on it too, but we don't use it. And like Dr. Moulson said, it's provider dependent too. Like a lot of the times they call it in, fax it, or like give it to the patient.
Perfect. Thank you for clarifying.
Thank you, Vince. Okay, moving on to the medication reconciliation. We want to know, is medication managed a major component of care in the clinic?
Yeah, from a cardiology standpoint, for sure. Yeah, we're managing all their cardiac meds.
Okay, and does the clinic maintain medication lists or histories either electronically on the EMR or on paper?
Yes, in the EMR system.
Okay, And is that normally done by the providers?
Yeah.
Okay. And will the medication list be reviewed and updated during each visit?
Typically, yeah.
Okay. And the previous medication list visit are saved as part of the chart, is that correct?
They are, yeah. So if it connects directly through iClinic to PharmaNet, and so you can pull their medical history, and then that is typically it'll be updated from the last time someone pulled that and reviewed the medications.
Okay, so it sounds like iClinic is also where changes to medication are documented in the chart as well. Is that correct?
Yes, yeah. Again, it'll depend on if you use it. If the provider is using documentation through iClinic, and then that pulls into their notes, then yeah, that's where it'll be changed. Sometimes it'll be documented in the note as well.
Document in the notes?
Yeah, the clinical notes, but it can also be documented through iClinic.
Okay. Sorry, maybe this is just something I'm not aware of. When you say document in clinical notes, what is that a different EMR system?
So it depends on, we can either document through iClinic or through PCIS at the moment. And so if it goes through iClinic, then the iClinic medication list is actually in the EMR system, and that can pull from PharmaNet. But if that's not what the provider is using to necessarily document on that patient, that may not be updated in there because they are doing it through the PCS dictation system.
Great, thank you for clarifying. And does the clinic do medication reconciliation? And if so, who does it?
So all that would be through the physician, and that would again kind of be at the time of the appointment.
Great, thank you. All right, moving on to case conference. We want to know, does the clinic do case conference in the unit?
Not through the medical clinic. We do case conferences within our kind of sports cardiology clinic, but that's separate.
Okay, thank you. Then take care of that slide. For future change, so we want to know, are there any future change planned for the clinic? For example, staff size, resources, location, clinic size, or change of hours, anything like that changing with the clinic?
No.
Oh, and Lauren, I kind of see your head shaking. Is that a no from you too? Okay. Great. Thank you. So I'm going to ask the team here, the CST team, if they have any additional questions for the clinic.
I think there's some good takeaways. I wrote down a bunch of notes, and I'm going to help sort of pass along some of my knowledge around some of the points that we talked about today, so we can represent those well in the next sort of sessions for you all.
Mary, I do have one question for Dr. Moulson. I'm just wondering, so right now, current state, Michele is registering the patients in PCIS, but I'm wondering, is there any reason that registration is currently happening in PCIS other than dictation?
No, I was just going to say that the major rationale for that is just an ability to dictate the patients. Yeah.
And is there any reason, or is there any sort of hard and fast rule as to which patients would require a PCIS dictation versus not?
That I'd say provider dependent.
Okay.
So some would only use the dictation system for that, whereas others will use iClinic predominantly for the dictations.
Okay, that's great. Thank you.
And that's one of the things that when we come around to look at sort of the options of what to implement and what not to implement in Cerner, that we'll bring back with that. There's some parts of Cerner that do things really well. And I think that we would probably want to treat the patients consistently, because it's like once you do the triage, the patients are all the same, like regardless of where they come from. So I think the parts that we'll bring back are looking at the options of what makes sense to do some overlap with Cerner, just to provide some of the Cerner tools that will provide an uplift, knowing a telephone dictation's going away and those kind of pieces that we have to take into account. So I think you have a very good, I'm excited that we're working with you because you seem to have a very good understanding of what we can do to do some big damage in a spot. You want to avoid that. So we'll definitely bring back all those pain points and avoid some of those, knowing that there'll be some points where we probably have to do double duty in both systems. And that's kind of the rub of having 2 EMRs in the same spot.
And I just had a question. I know we were on a slide before about provider documentation. Dr. Moulson, you mentioned that there are shared templates in iClinic, but it's, you know, at the discretion of each provider what they want to use. Do you think you would want us to build out, you know, those templates in Cerner? And if so, could you provide us like an example copies of those templates easily from iClinic? Is that easy to export or even to print out and send over?
Yeah, I suspect that would be. I guess that will depend a little bit on like what percentage. Like I feel like I guess, and that'll be a question I think that we'll talk about with Eric. Is how much, like, if you want 2 different avenues to be able to document through that sense, like if we're going to be still primary iClinic and then having CST as a separate, because that's kind of where we are right now in some ways, is that we can use PCIS versus iClinic based on the provider preference and the way they want to do that. And I'm not sure if that's the model we want to continue forward or finding more of a standardized way. And I think probably
we'll definitely get more into that in the design. I like with Cerner though, if you document in Cerner, there's distribution so it can come back to iClinic. So that's just a nice piece.
Okay, if that's a possibility where you could document in Cerner and send it to iClinic for people that would prefer that, I think there would be some benefit there, just from my personal opinion. So I'm happy to share some of those templates. They're pretty straightforward. Yeah.
Share the templates with us. I think that'd be really helpful. Since we're talking about this now, that's a really good point that Neela did bring up, and that's sort of where there is going to be a little bit of individuality allowed based on provider preference. We usually recommend that the note ends up in Cerner. If it's generated initially in iClinic, you can cut and paste into Cerner. That's like not a problem. And then use the functionality in Cerner to get it into Cerner and then also distribute it everywhere, which is, you know, really beneficial. And it helps with the patient's record overall. I think the other part is you've been using Cerner now probably in some spaces, and you know how there's like all those controls, like the medication control and the problems list. A lot of cardiologists have chosen not to use those because your appointments are quite tight, you're busy with folks. And so Annie Chu has developed some templates already from when they did this exercise over at Providence. So we do have those as an example. You can even look at them right now if you use the auto text copy function and just look at her templates. So they are available as an option that we've sort of utilized elsewhere. So there are some things that we can do to sort of provide you with examples, and the ones that you have, we can do the same thing with.
Great, thank you. So that sums up our requirements gathering session. I just want to give an opportunity to the clinic to see if there's any kind of workflow or anything that the clinic does that we didn't get a chance to discuss. Anything from the MOAs or the clerk side or the provider side that wasn't touched during this presentation?
No.
Okay.
No, I think we're okay.
Great, thank you. Then we'll talk about the next steps. So we have a tentative meeting from the scheduling session that will be on April 5th from 1 till 3 p.m. And also a design session with the CST team, tentative for April 25th from 3 to 5 p.m.
So Mary, have we made some decisions on how we're going to proceed with this? I thought this was information gathering, and then how does the decisions get made about next steps? Is that what that scheduling session is, or is that more to show what the design will be?
It's a great question. So to clarify, so for the requirements gathering session, we're here to understand the workflow and what's needed for the clinic and how we can best match that with the functionality of Cerner. So the next session, a continuation of this would be the design session. That is where we will discuss what we can do in Cerner and give you a taste of what Cerner can do, and we'll demo the functionality of Cerner as well. The scheduling session, it's more about booking your patients. It's going to be with just the scheduling team, and they're going to help you organize the scheduling book of the clinic and map that out to the resources as well. Does that help?
What if they're still scheduling an iClinic if they don't want to schedule in Cerner?
And that's one of the decisions that we'll have to have made. That's a really good point. Cerner scheduling provides a bunch of functionality that would be helpful, especially I think this will be a conversation where we have to have it with a bit of management and a bit of physicians and trying to discuss that. The scheduling in Cerner does bring the availability then to have the patients consistently in one spot. And then the other part of it is that if the patients, for example, booked in like echo or ECG, those are booked in CST Cerner as well. So you'll see the schedule one space. Downside is you'll probably have to schedule them in both applications. So I think that's something we need to come back and present to you the options of what this could look like and what that means. The good thing is then if they're coming to the front desk, Michelle will be working in Cerner, and then she'll be able to check in all the patients there too. So I think there's some benefits and some drawbacks, and we have to just sort of bring it back to you all to discuss.
Yeah, and I think that typically happens in the design session where we'll present to you, the proposed future state workflow. And then maybe knowing now what we've gathered today, we'll likely come up with, a secondary workflow from you guys to see the differences, the pros and cons of each. But I think today's session was really great, and that'll help the design team build out like the different options, because there are, I think, as we mentioned at the beginning, there are some non-negotiables that things that need to be in CST Cerner. So those would also get highlighted there in our design.
And just to throw it out there too, like there's not really a right decision to be made. Like we'd have a recommendation, but there's like workload implications for your MOAs probably a little bit in there. That being said, where we ended up landing with PHC is initially they weren't scheduling in Cerner, they were just registering, and now they're doing both. So they, I think over time realized that the best course of action was to do the dual scheduling. So we'll bring that up. We'll bring you the options analysis with all the pros and the cons. But we did see movement in that space from not using scheduling to all using scheduling, or almost all of them using scheduling. So it did change over a period of time.
Thanks, Eric. Just wanted to bring it to your guys' attention that we do have multiple cardiologists that work on the same day, with multiple testing also booked to cardiology lab for diagnostics. So we will need to be able to see all those tabs and all these appointments and stuff. So just something to keep in mind.
Okay, yeah, and so we'll probably get some, we'll probably just get some feedback as well from PHC. You could always talk to Nate, you could always talk to Annie Chu and see what she was like the driver of a lot of this like mirror workflow at PHC. So she'll probably have some good feedback that's like, realistic, and I would recommend just connecting with her. And if you have any questions based on that conversation, you can just feed them to myself or to any of the team members here, and then we can sort of help answer them.
Yeah, thank you.
And I just wanted to say just a correction to the slides. Sorry about that. Everybody, the actual next session for the requirements gathering for scheduling is for the 20th of March between 2 to 4 p.m. And then the design session itself will be scheduled for April 3rd. So April 5th, yes, April 5th. And then the last one, that's the validation session. So you should have received by now all the invitations.
Great, thank you very much. Oh, yes, Faisal.
I was just gonna, in my head, I'm just trying to summarize the current state right now. The current state is that everything occurs in iClinic except the patient is registered on the day of arrival in the medical clinic. Is that a good summary, Michelle?
I tend to register the patients or extend their account 1 week before, just so it's ready. Of course, there's going to be changes, but I tend to register 1 week ahead.
That's what I mean. Essentially, everything is occurring in iClinic except you're registering them in PCIS. And the change that we're looking at now is that they will be registered and scheduled in Cerner. And that's what the team's going to go back and come up with a way of how they can make it work for cardiology at UBC.
Right. And okay. To be clear, registration is mandatory, scheduling is not, but we would probably recommend it, but it's not something that, like, I'm not going to die on my hill. I'm not sure if any other people will disagree with me, but we'll come up with solutions, and really it's like looking at the different pieces of the Cerner that will give you functionality based on the decisions that we made, and go from there.
Excellent. Thank you, everybody.
Great. So we're almost at time here. It's now doing a time check, 8:56. Does anyone else have any questions or comments or concern that you would like to address during this requirement gathering session? Okay, well, like tutors say, we will look forward to our design sessions coming up next. I really want to give a big thank you for everyone that participated during this requirements gathering session to facilitate a wholesome conversation, allow us to bring a lot of information back, and we will look forward to providing options that we can provide for you in Cerner during the design sessions, and we can further on and communicate how we can implement the system in your cardiology clinic. Thank you, everybody.
Thanks, everyone.
Thank you.
Bye.
Thank you.